We have spent the morning looking at resilience, systems, financing, and now we're going to turn and speak about the people that make things happen. Our next session is Training Tomorrow's Healthcare Workforce, the role of academic partnerships in health system strengthening. This session is a special collaboration with our partners at the Department of Global Health and Social Medicine at the School of Medicine. To frame the discussion, please welcome to the podium Dr. Joseph Radigan, Associate Professor of Medicine and Paul Farmer Chair in Global Health at the Brigham and Women's Hospital here in Boston. Dr. Radigan is also an Associate Professor of the Department of Global Health and Population at the School of Public Health, and an Associate Professor of Global Health and Social Medicine, and Director of Curriculum Development for Global Health Delivery at the Harvard Medical School. Dr. Radigan, please join me.
I'll invite our panelists to come up. So as you all know, people, the healthcare workforce, are essential to any well-functioning health system. And well-functioning health systems ensure that their healthcare workforce have the skills and the supports needed to do their jobs. Unfortunately, we're facing a very large deficit of skilled healthcare workers. This is due to many issues, including the aging of the global population, increased burden of disease, more people living with disability, the underinvestment in health professional education and health workforce training, and frankly, the untenable job situations many people find themselves in with burnout and health systems having a hard time retaining skilled healthcare workers. As we seek to improve global health equity, we will need to find innovative ways to increase the number of skilled healthcare workers. And that is what today's panelists will be discussing. I would like to now introduce our speakers for this plenary session. Professor Bebe Bekele, who is the Deputy Vice Chancellor of Academic and Research Affairs and founding Dean of the School of Medicine at the University of Global Health Equity in Rwanda. Dr. Shriram Samasunda, Professor of Medicine at the University of California, San Francisco, and co-founder and faculty director of the HEAL Initiative. And Dr. Apara Parikh, Associate Professor of Medicine at Harvard Medical School, gastrointestinal oncologist and director of the Global Cancer Care Program at Massachusetts General Hospital, and Dr. Ingrid Bassett, who will moderate today's session. Dr. Bassett's a professor of medicine at Harvard Medical School, an infectious disease physician at Massachusetts General Hospital, and the co-director of the Harvard Center for AIDS Research. Great.
Thanks so much, Joe. We're really excited for this panel to be standing between you and lunch. No, I'm kidding. We're really excited about this panel because I think today many of the panels are focused on extremely high level, governance, priority setting, emergency preparedness. This panel, I'm excited we're going to be able to delve deeply, hopefully into the technical aspects of health system and health workforce strengthening across multiple models. We have our panelists focusing on different areas. So we have a Bebe working as a dean in rural Rwanda, trying to quadruple the healthcare workforce in 4 years, a big goal. We have Shri as part of the HEAL Initiative, training cohorts of healthcare workers across different healthcare cadres, community health workers, physicians, nurses, to try to build capacity in rural areas and try to promote professional development and retention in the workforce. And we have Aparna specifically focused on the oncology workforce, medical oncology, radiation oncology in Africa, really trying to develop African oncology leaders. And while these are different, I'm hoping what we'll come through this panel with are some of the common threads that really help inform how partnerships for training and healthcare workforce development, how they should look and how they should be, their architecture to be the most effective. So I think we'll go ahead and start with a Bebe. I think I'm going to ask each panelist to set the stage a little bit in terms of, how workforce depletion shows up most starkly in your context, and then we'll spend the rest of our time sort of focused on how you're addressing that. But can you just set the stage for us?
Thank you. So happy, so proud to be among us today. Thank you for the invitation. I can mention two things. One is you probably will have a lot of patients in your waiting list. I'm a surgeon by training, so one manifestation is a lot of patients who do not have access to any sort of care. Second would be, I'm also a dean of a medical school. You are trying to recruit qualified people to a certain position. The vacancy stays open for months and months, even years. You have to look at other ways of filling this position. The third might be from a policy perspective is you look at really difficult policies to understand coming out of ministries. Intense focus on task shifting and task sharing instead of focusing on producing the right professionals. The sudden explosion of medical schools in a country, 5, 6, 7, 8 times fold in a few years. That is a sign of a chronic deficiency of workforce in a given setting.
Thank you. Shri, how about you?
Sure. So yeah, thank you for having me. So the program I run is at University of California, San Francisco. It trains different health workers across many different sites. So in Navajo Nation with indigenous health workers, rural Californians, as well as 9 countries around the world. And I think one of the things that we see over and over again is that in all of these places, health workers, they're too few, they're under-supported, they're overwhelmed. And so the structural instability and the structural violence of the health systems, the natural kind of outcome is people making decisions to leave, to not be retained. I think Joe mentioned burnout and the moral injury that comes with doing this work and not being supported and not having a pathway to grow. And so I think the consistency across all of these geographies that I see is remarkably similar.
Thanks. Aparna, how do you think about this as it relates to specialty care?
Yeah, I mean, so just to level set for those of you who may not be aware of the cancer statistics. So when you look at the cancer burden, around 70% of the cancer incidence and mortality is happening in low and middle income countries. And when you look at just the workforce, so just pretty stark numbers. So in Boston, we probably have 200 to 300 oncologists per 1 million. And I think if you look in parts of Africa, we're talking about 1 in 1 to 2 million. In terms of just access to even facilities, if you look at radiotherapy, for example, less than half of African countries have access to a working radiotherapy unit. Oncology in particular, I think, is incredibly challenging because it requires multi-subspecialty care, it requires pathology, it requires diagnostic capability, it requires surgeons, radiation oncologists, medical oncologists, noting that in the African training model, many of the medical oncologists are actually the ones also delivering the radiotherapy as well. And then, of course, the importance of the palliative care as well, since the majority of patients are actually diagnosed with late-stage diseases. So I think we're starting to chip away at parts of this, but I think the continuum and the spectrum of care required for oncology patients is incredibly complex and a tremendous deficit in terms of just resources and limitations.
Super, thank you. I'm hoping that you can each describe a little bit about the models that you have developed to address these gaps, specific training models and partnerships, and really thinking a little bit about how these are designed to address the gaps that you've just described. You can go ahead. We'll start with you, Shri. Go ahead.
Sure. So I kind of came of age working with Partners in Health in different settings, and I was in Haiti after the earthquake. And I think one of the stark things of seeing, after the earthquake, even months after, kind of thinking about Haitian capacity building as an afterthought instead of kind of at the forefront. And so we started HEAL in 2015 and really started working in Navajo Nation and many other countries around the world. And in Navajo Nation, which is the indigenous community in the southwest of the US, there's a 30% vacancy rate. And oftentimes, they're using temporary staffing to fill their jobs. And so what we did is we basically combined, early career physicians coming out of residency that wanted to do social medicine, wanted to commit themselves, and we had them share one job in Navajo Nation. And instead of that money going to a temporary staffing company, it came to HEAL, and we supported 2 Navajo health workers, 2 Malawians, 2 Rwandans, and some US post-residency fellows. And so the model is really about interprofessional training. So we have community health workers alongside nurses, alongside doctors. I think that's super powerful, as well as training in rural settings. So having workforce and programs that actually exist, because we know that where people train is where they remain. And so I think those are some of the innovations, and then obviously trying to in our programs not be have some of the voyeurism of doing international work, but combine it with a domestic commitment as well, and then trying to have a model that makes use of poorly used market failure government funding to cross-subsidize the work.
So some cost sharing.
Yes.
Okay. Baby, I'm wondering if you can talk about the model that the university has taken on. I'm thinking about the kind of structure of the partnership, a lot of people, coming in to Rwanda, and how you think about that, how you kind of manage the partnerships, which are quite extensive and I think really important to the success.
I work for the University of Global Health Equity. This is a university 2.5 hours away from the capital city, Kigali, deliberately placed in this rural part of Rwanda called Butaro. Behind us is a district hospital. In front of us is a green space, completely rural, after a concept called place-based education. We expect graduates of any medical school to go back to a rural community and serve after graduation. And yet we criticize them when they can't. They burn out after a year, they decide to leave the job and return back to where they came from. One of the reasons is because they're not prepared to serve that role. What you try to do is, what if we train them in the real rural part of Africa? It takes 6.5 to 7 years, and they graduate with 2 degrees, their medical degree and a degree in global health delivery, a master's degree. We're trying to prepare them to serve that specific role. In the district hospital, they're supposed to be leaders. Many of them are medical directors, sometimes the director generals. At least they lead a certain healthcare system. Many of our graduates sit in the ministry, including the state minister of the country. We are trying to prepare them specifically for that role. And they also need to be really good doctors. General practitioner in Africa serves a different purpose than the practitioner probably in North America. Internship is not the first-year internship, residency program. Internship is junior doctorship. By the time they go to a district hospital, they take care of everything. Surgery, maternal health, pediatrics, emergency, you name it. So we are preparing them really well to serve that role. How does the partnership come into UGHE? In fact, it's a classical example of what governments and NGOs can do if they really work together. The partnership between the government of Rwanda and Partners in Health is really amazing. The direct support we get, the free land we enjoy from the government, the open door policy with all the ministries, including the High Office, the day-to-day encouragement, the support is really valuable and really instrumental. Partnership with funder institutions is also instrumental. A classical example that non-vertical funding, transformative, substantive funding can actually bring about good change in academia. And then the way education and research is delivered at UGHE is also partnerships-based. If you look at the definition of global health equity, it's about products, partnerships, and processes. Without partnerships, there is no global health equity. And that's why we carry the name global health equity. partnership is a key pillar. So we work with whoever is willing to work with us, provided we share the same value. And the value is equitable access to healthcare, particularly to the vulnerable, to the underprivileged. And we work with a lot of academic institutions in the world.
Thanks. Should we go ahead? I'm just thinking about your sort of training model.
Sure.
And how you think about that across the different workforce cadres.
Yeah, I think our model has shifted over the years where, I think we have 5 pillars that we focus on. So at first we, were interested in teaching some of the clinical competencies, but we realized that, a lot of, if you're working in rural India, the local workforce there, the faculty there are much better at teaching TB, for example. And so we've kind of shifted our work into very specific social medicine pillars. So really around leadership, around structural competency, advocacy, well-being, this idea of understanding your power and position as a physician, to both from a standpoint of leveraging that power, but also having humility. And so those are the 5 pillars. And what's been incredible to watch is the case studies that have come out of the clinical scenarios that exist, in real time that our fellows are dealing with, and turning that into cases to learn across this shared network globally. And so we just had a global health book called Illuminating Global Health that got published, and it's fascinating because it's cases from Haiti, Chiapas, Nepal, India, Navajo Nation, and it's really a collaboration between very rural, committed workers from those communities, bringing clinical cases and then combining them with social scientists that break down kind of the structural reasons people get sick, why this outcome happened, and then I think that's an example of like just having an education that is informed from the ground up in our curriculum.
Thanks. Aparna, how do you think about this for specialty care? I know one thing that always would worry me in South Africa when I wanted to meet with people, say, boarded in infectious disease, it was a very limited number, and every time we would pull them away, we felt we were sort of robbing Peter to pay Paul, so to speak. And I'm just wondering, can you describe a little bit about your model and how that works?
Yeah, 100%. I mean, I think we're very acutely aware that we don't want to contribute to the further resource drain that are already facing and workforce drain. So I think what we did back at around 2016 or so, at a meeting, a cancer meeting in Africa, we started to have conversations with 2 of the larger training institutions. So one, the Ocean Road Cancer Institute in Tanzania, and then the other, University of Cape Town, that was training, oncologists, a large proportion of the oncologists. And I think what was very explicit with the training programs is they felt that the opportunity to spend some time with us, looking at not necessarily just the access to novel therapies and things, but just very practical things: dosimetry, chemotherapy safety administration, quality and safety metrics. How do you set up tumor boards? Very, I think, practical type of information that they thought could be delivered in a concentrated format. I think 2 things that came up consistently was, one, the time. I think, how much time did they want people to spend there, because it was going to hurt their own patients and their own staff if we had them come for too long. And then second, letting obviously them kind of pick who they wanted to come, with very much intentionality around who were the people they thought they were going to stay and lead in country, right? So as best as you can pre-select those folks that would be the next generation of African cancer leaders, allow the training programs to select who they think that might best benefit. So we started in 2017. We had, pre-pandemic, around 8 to 9 come and spend time across a couple of the different Boston hospitals. And I think what was really valuable was not only the exposure, but I think the networks and the access to people. And I think we were very intentional around mentorship too, even for grants. And many of those early kind of fellows subsequently ended up getting, various career development awards and NCI grants, and have maintained kind of connections with Boston-based faculty too. I think the other thing, it was a little bit cringy for me, because we'd have these Boston oncologists dial into some of the tumor boards, and you're so out of context in terms of what is available for patients there. And so what we were able to do amongst the fellows that consistently came was create a community of practice amongst themselves. And so they can look to each other to provide case support and management. And we're always there to provide help as needed too, and frequently get asked to weigh in, but rely on each other. I think they have the smarts and the wherewithal entirely to kind of help guide each other. So create a structure for them to be able to communicate with each other. So we've slowed down post-pandemic just for various reasons, but I think still really has been anchored around partnerships with the training programs.
I think that for us to, the community as infrastructure and belonging as infrastructure, because a lot of these rural health providers are just, they're not getting the support, or, the academic centers that might be in Boston or San Francisco can't provide them the context that they're living in. And so having this shared cohort, this global solidarity across, all these health workers, I think has been core, and it allows people to sustain in the work too.
Yeah, I was thinking about the HEAL cohorts as you were talking, in terms of the previous cohorts serving as resources for the current cohorts, and the kind of training the trainer, that aspect of HEAL, I think has a certain resonates here as well. Okay, well, we're going to pivot a little bit to talking about how you align the training with the populations you're serving and the systems where you're functioning. And so thinking a little bit about how you kind of anchor your programs into the everyday reality, in terms of how you're defining the needs that you're aligning with. And, Aparna touched on this a little bit, like balancing, the realities of what might be available in a rural or low resource area with what international training standards are. So I wonder if you could talk a little bit about defining the needs, and then how you're balancing that.
Thank you. I guess you were talking about curriculum. One of the issues the continent of Africa has is it is yet to define the kind of doctors it wants. Are we following the North American model, the European model, that is probably 100 years old, and copy-pasting it to Africa? Or does the continent, has it yet identified the kind of practitioner it wants to serve its purposes? What is the job description of the doctor? We don't have that. The job description leads you towards the competencies. What are these doctors expected to do in terms of the domains, knowledge, attitude, and practice? We still did not have that. So the very first struggle we had at UGH was trying to define that. Assembling the right expertise, looking at the burden of diseases in Rwanda. What are the common 10 diseases, 20, 30 diseases? How do we create curricula, syllabi out of that, and then create the content? It took a bit of time. It's still an ongoing process. Mm-hmm. Luckily, I'm glad our colleague from WHO Afro is here. For the very first time, a couple of months ago, WHO Afro took leadership in owning curricula in the continent. They rolled out 10 curricula for the very first time. It's still a work in progress, but that's step one. Now, once we identify what these doctors, practitioners are supposed to address in the country, dealing with the knowledge that's in the practice is reasonable. Mm-hmm. The second challenge is, do we have enough expertise as faculty, as mentors, as teachers to deliver the content? Unfortunately, the answer is a no. And not just in Rwanda, it's across the continent. So we depended a lot on partnerships. Partnerships are not gifts, are not donations. These are bilateral things. UGHE had strong relationships with Harvard. since the very beginning, from its inception, its visioning exercise, curriculum development. So it's natural. Being an implementing partner was not difficult. The key was the shared vision. Not the key goal, but the key vision. Why are we partnering? To achieve what? It's not to produce doctors, but what do the doctors do? What is the ultimate vision? It's about the vulnerable, it's about the poor, the underprivileged, equitable access to healthcare. So that is how the defined competencies fed into the partnerships we have.
Thank you. Okay, Shri, I'm wondering if you can also think about this in terms of how you are keeping your work anchored in the populations that you're serving, and also, any feedback you've gotten from partners that has then changed the way you do business. And you alluded to this a little bit, this sort of progression or evolution from your initial model till now.
Yeah, I mean, in terms of the clarity on who we partnered with and why we do this work, the goal is to train health workers that are accompanying resource-denied populations, poor populations, and stay in this work for the long term. And so I think our program has definitely evolved in a big way, in that a lot of the now we have several hyper-local cohorts around the world. And so we have a cohort in Mexico that's in Spanish. So one of the responses from some of the early Mexican fellows that were counterparts, they came to the US, they did some training. A lot of them said, as powerful as this work is, there's my counterparts that don't speak English, don't have a passport, that are in the public sector that would benefit from this training. So they've adapted kind of the pillars of what HEAL started with and made it specific to their context. And same in Navajo Nation, I think there's been a lot of Indigenous women that are alumni of HEAL that feel like the way we mentor, the way we need to integrate Indigenous ways of knowledge need to live in that cohort in a specific way. And so they've indigenized the curriculum, they've adapted the mentorship for their context. And so now it's mostly Indigenous HEAL alumni running a cohort for Indigenous nurses in Navajo Nation and Zuni Nation. And so I think that essentially it's just living in the work and evolving the work based on what our counterparts across the world are telling us. And I would say those are some of the adaptations. I think when the U.S. providers, and this is probably consistent in, when people practice in capital cities. One of the, one story was our rural Indian faculty lead was telling us that some of the U.S. doctors that would come to India were pushing a lot of the patients into debt because they would come in and they didn't have the context, and they were saying you should get this CT scan because they would order that CT scan in San Francisco, and the patients would comply, go sell off their land, or and so there's a lot of I think being responsible and responsive to the context that you're serving, and ideally it being driven by the people closest to the work.
Super. I wonder, Aparna, if you also can talk a bit about like the population health priorities and that tension with the everyday service realities.
Yeah, I mean, I touched on this a little bit, but to dive a little bit deeper in terms of just the priorities, I think every training experience is really fit for purpose. I think based on where they're ultimately going to go practice, what disease areas. Breast cancer obviously comes up as the #1 tumor type that they want a lot of exposure to, so we ensure that we have that. And then not only working with the trainees that are coming, but the programs to really bolster, like, what are the other skills that I think can help strengthen just the cancer care delivery model, that some exposure could be useful. I think one practical example of this, one of the Kenyan oncologists who was very interested in clinical trials and how to set up clinical trial capacity, particularly with some industry-sponsored trials, has spent a lot of time with every function role group around the clinical trial pipeline. So in cancer clinical trials, there's regulatory, there's the budgets that are really important to build some infrastructure. in a health system as well. And so I don't think we had a one size fits all. It was really sort of tailored based on what the need was at that time and what they were hoping to get out of the time here.
Thanks. All right, we're going to turn a little bit to the kind of concepts of equity, reciprocity, and sustainability. So we've heard a little bit of this. Abebe said, this is a two-way partnership. But I'm wondering if you guys could speak a little bit more about the partnerships in terms of how you bake equity and reciprocity into them, and any of the kind of design choices you made to keep the power balance such that both sides are seeing the benefit and not feeling neither dependent nor in control, but really in true partnership.
I guess I can start.
Go ahead.
I can mention a few things, and but I'm sure my colleagues will add on to that. I think the very first thing is the shared vision. You can't partner with a group or an individual you don't share a vision with. It's not about doing this job and then part ways. It's a journey. It's a long-term journey. The second is, I think the friendship is critical. That fellowship, that friendship that predates the partnership is really, really helpful. That trust building. This decision is on my favor, on my behalf. I trust this partner. That is critically important. During the partnership process, conflicts will be there. Misunderstandings pushbacks will be there. But if the friendship and trust is there, it's easy to navigate this. It's easy. The third is it should indeed be a partnership. At UGHE, we receive several visiting faculty from universities. It's not just the teaching. They are part of the department. They join the department meetings every month. They are in the curriculum planning team. They are consulted during exam preparation. They are consulted during graduation. Most of them are invited to graduation. I hope we could afford to pay for tickets for everybody. Because they are part of the institution. So they should be part of the decision-making process. These three I have found very, very important. Maybe one last point would be partnerships don't end. I guess they transform. It would be probably a bit naive to think, it's for a 5 years thing, I'm done after that. If there is friendship and trust, I don't think it's going to turn out that way. The partnership morphs, changes into something else.
Thanks.
I would say, some of the language and practice, like the rhetoric of global health partnerships kind of outpaces the practice and the living into solidarity, solidarity as a verb, and really operationalizing equity, because, we talked about solidarity as risk pooling. And I think most academic medical centers in global health have come up as serving kind of the US trainee in some capacity. And so to actually live into work that doesn't replicate those systems and those power dynamics, I think is very difficult. And oftentimes the language of what we hold up and the actual reality diverge. And so I would say for us, it's, trying to have governance around, who gets to decide how the program unfolds. For example, I think some of our local fellows or site fellows, the community fellows that join the cohort, they would say that, how come we don't get to travel, right? And so there became these exchanges where a lot of Haitians went to India, and Indians went to Nepal, and Nepalis went to Liberia. And so there's this cross-collaboration that came from their voices, right? And then I would say that, in global health, there's phenomenal programs and faculty, but oftentimes we need our institutional partners to have, the institutions we live in to have skin in the game. And I would say that, in our work in Liberia during Ebola, we had a program that was running there. And, I think the risk aversion of the institution was they wanted to pull back, right? And we see that time and time again. And so we need kind of the level of academic medical centers to live into, because I feel like power analysis and the ability to take on power is a core global health competency. So you need your institutions to support when you're operationalizing in that way.
Super. How about you in terms of thinking about the reciprocity, the sustainability?
Yeah, I mean, I think as I was mentioning post-pandemic, one of the reasons we slowed down a little bit was a pure ask of the training institution. So they said, I think 8 is getting to be a lot. It's a strain on us to send 8, so we still want to send, but can we just come down to 2 or 3? So kind of a small example of that. And I think what you said really around the friendships is so beautiful, because these partnerships and friendships grow over decades. And I think, from our perspective too, it's also just the sponsorship of these young oncologists in the global context. And so, if it's coming up at our American Society of Clinical Oncology meeting, who do you want to put on the podium for a talk, and who do you want to put on an editorial board to get some representation on editorial boards? And so I think it's not only in the moment, but I think it's that long-term partnership of how you can promote and kind of sponsor to continue to develop the African leaders.
I'm glad you touched on the scholarship piece. I'm a researcher, in my heart, and and we might get questions about this later from the audience, but just, I think part of the reciprocity and equity is that people locally are generating the knowledge and are having the opportunities to shine on the global stage, at conferences, in manuscripts and so on. So I'm glad that came up. The kind of authorship piece, the career advancement piece, I think it's really important, and that is the kind of really walking the talk. All right, I want to look ahead a little bit. And so thinking about designing these partnerships, for impact into the future, kind of taking a step back from, the problems you've solved and where you are today, and really thinking about, what might need to change structurally, politically, in another way, so that these academic partnerships are ready to take on the future for the healthcare workforce, which could include, AI or other things that are coming down the pipeline, which will inevitably change healthcare. How do you see the future for your partnerships? How should they evolve?
I guess the future of global health will be partnerships. Without partnerships, there will not be any global health. So far, things are fine. The past 10 years have been really...
I'm glad you feel that way.
I'm very optimistic, because I am a real beneficiary of what partnerships can achieve. We work with quite a number of academic medical institutions from the US, quite a number. And most have been very productive, equitable, power balanced, productive. So I don't think I have too much to complain about partnerships. I think the future is going to be partnerships. In fact, what needs to change is we probably need to look internally. It should not just be north-south partnerships. The north-north collaboration partnerships are really meaningful. And that is why last year, the University of Global Health Equity, together with our friends from HMS, convened 115 medical schools in Rwanda. This gave rise to the formation of the Consortium of Medical Schools in Africa. At the moment, 71 medical schools are members.
Wow.
The next conference is going to be in July in Addis Ababa, maybe next year in West Africa. This is the inception of the American AAMC, which is 150, 60 years old. So partnerships, even though really, really beneficial north-south, we need to look at south-south. There is a lot we can share. Most African countries, the same burden of disease, same issues, same opportunities, same future. It's a youth-dominated continent.
Yeah.
It's only reasonable, logical, to find solutions together.
And potentially the solutions to the issues you brought up earlier around like a common curriculum and what should the job description for a doctor look like. And so it may be that COMSA is the way forward for that. Super. Shri, how about you? What do you think? What needs to change? What do you see in the future?
I mean, I like what Abebe said, because HEAL partners with the UGHE. I think UGHE is one of these models of the Global North institution essentially, has to line up with the priorities of what the needs are with UGHE. And that is obvious, but that doesn't often happen in global health. And so seeing more partnerships where it feels like a level playing field. You still have too many like very short-term fly in, fly out. You're not responding to the global burden of disease, what the health workforce needs, and the agenda is set in the global north in an academic institution very far away from the setting that you're working. So potentially seeing more UGHE-like partnerships where, when our fellows go, it's a very clear, this is what's needed in Rwanda, in Butaro, in this context, this is how you're going to contribute. And I think that's important in all of our partnerships.
Super, thank you. Arna.
Yeah, I mean, cancer can be a little bit overwhelming, I think, to think about because of, all the people that hit a patient in their journey. And, as we were just having this conversation, I kept kind of thinking back to like, man, I wish we could really figure out something for just oncology nursing, right, in a more systematic way, and what an impact that would have. And was thinking back to 20 some years ago, some time I spent a couple years in Eldoret, and I think Butaro is the same now. I think actually has true oncology services, but in the start at some of these places, it was the just general medicine folks like giving the chemotherapy and trying to understand. And I think we can aspire to having a growing oncology workforce, but until we get there, we still need to care for the patients. And so how do we continue to support the other role groups that are going to be touching the patients? And I think that's my sort of wish list of trying to get there. But that's a big task for all of us to think through together.
Shri, can you maybe comment on that just in terms of, I think HEAL, uniquely focuses on multiple healthcare worker types and how you came to that? Because it sounds like that could be very helpful in oncology care. I just wondered if you could reflect a little bit on how you got there and how they interact with each other.
Yeah, I mean, I think physician training often, like in so many parts of the world, is kind of you're disconnected to the populations that you're serving in some ways. And even if you trained in Mumbai, for example, you don't really have a great context as how your patients live their lives, potentially, if you've come from kind of a more middle class or upper class background. And so really, the doing home visits, for example, accompanying community health workers, that's like where the greatest learning happens. And so oftentimes our cohorts have, just nurses and community health workers and behavioral specialists, and that richness of different lived experience and how that informs how we practice medicine, because there is being an excellent clinician, and then there's actually being relevant and useful, because all medicine is delivered locally, right? And so really understanding the populations that you're serving and some of the structural violence and structural challenges that those patients have. I think having mixed cohorts where oftentimes, the CHWs that join the cohorts have 10,000 times more knowledge about delivering healthcare than somebody who trained in a big city. And so having them benefit from seeing themselves in you, because they're in a room with a physician, and that sometimes is not useful, and they realize they're just as incredible and so some of it is just holding a mirror up to phenomenal leaders that kind of can see themselves as phenomenal, because they're now in a global conversation, because they're in a room with different cadres of professionals.
Maybe I would add one other thing I think it's important for oncology, and is sort of how do you layer on to existing kind of primary health services too. I think there's such a late stage presentation, and one of the Brigham docs, Lydia Pace, has done some really nice work around breast cancer screening on when you're coming into to care for other reasons too. And so I think one of the key aspects, I think we're focusing a lot on treatment, but if you go back to my initial numbers, most cases are diagnosed late, and so how can we provide awareness, education, kind of stage shift, so you're getting earlier stage disease, and a lot of that is education and opportunities to layer on to existing existing health systems and primary healthcare services as well.
Yeah.
Do you want to comment?
I don't think I'm going to be helpful, but let me try to complicate the situation further. I'm a surgeon, so I am closer to the surgery numbers. When you look at the SAO, surgeon anesthesia obstetrics density, this is a figure WHO uses. The minimum expectation is 20 per 100,000 population, preferably if it's 40 per 100,000. And just to give you the context, if you go to the American College of Surgeons website and check, it's 48.1. And yet there is a line below. The US has a shortage of 19,000 surgeons. Now, look at the number in sub-Saharan Africa. It's 0.53. And again, to complicate things, 87% of these surgeons are in the capital cities.
Mm-hmm. Wow.
This is an inequity within inequity. Mm-hmm. Further, I was really intrigued when you mentioned cancer care was provided by internists. What else is the option? Because the rural part of poor part of Africa is completely neglected. It's completely neglected. That is why the workforce development and the training tomorrow's health workforce is critically important, and training the right professional for the right description.
Super, thank you. It's provocative, I like it. Okay, I'm gonna go ahead and open up for questions, either in the room or if Princess sees anything online. Any takers in the room first?
Okay, here we go. So one of the questions we have is, how can universities and community-based organizations co-design academic partnerships that not only train health workers, but also create local economic opportunities and long-term system resilience, especially in contexts bridging both local U.S. communities and international development settings?
Wow.
Easy one.
Tough question. Are we taking more questions?
Oh, yeah. We can maybe
Piece that question.
we can let that one sit for a second. Okay.
Thank you very much to every one of you for this very insightful exchange. I'm a Salata Berke Fellow on Climate and Health, and I would like to ask a little bit, tapping into our last panel as well. In your experience, what are the curricular competencies that matter most right now, given the climate change and the shortage of workforce, not only to navigate the clinical scarcity, which we have been talking about much, but also to grapple with the governance and human rights questions that climate shocks bring into the scene. For example, heat waves and maternal health, or floods and children's health.
Super. Okay, so maybe we'll start with how can universities and CBOs train healthcare workers to create local economic opportunities?
Yes, I think the very first thing governments need to do is define what kind of professional they want. Professionals are not just community workers. They are not just surgeons. They are not internists. It involves everybody. Then do countries in Africa have these mapped out? How many surgeons does Rwanda need today? And then define, how do we get there? One of the mechanisms is working with partners, with others. And in my opinion, until that very first step is taken, until we really define what we want, when we want, who we want, it's really going to be difficult. It's really going to be difficult because we don't know what. There's a saying in Africa, Barnabas knows this very well. If you don't know where you're going, all roads will take you there. That's exactly what's happening now. What are we heading? Where are we going? How many surgeons am I trying to produce? When? If that is really clear, then the rest is, I think, technicality. I would start from there. And the partnerships with governments in policy, in development, is really helpful to define this in the very first place.
Let's say one of the things in our California work that we're doing, we're measuring retention of health workers in these rural settings, 2 years out, 5 years out, 10 years out. But there are many organizations, CBOs, government partners that are looking at, is there increased economic growth of the fellows based on their participation in a program like ours. And so for certain actors, economic development of these folks that might be, very low income to start off with, the only income in their family, and does participating in certain programs give them some upskilling and a pathway to grow their own economic development. And so I think there's a lot of conversations happening in California, elsewhere around that, and HEAL's trying to be part of those.
You want to comment?
Yeah, I mean, just going back to your comment a little bit, or even around just geographic distribution, I think the last time there was a survey of just some oncology training touch points, there was around 70 across the continent, but about 3/4 of those were clustered in like the north and the south, and then a smattering in the middle a little bit. And so I think back to your point, can you be a little bit more, being able just regionally focused too, to ensure there's even training opportunities that are well distributed in areas where currently those even training opportunities are pretty much non-existent.
Yeah, I think this is where regional collaborations become critically important. At the stage we are in, I don't think all countries will afford to start an oncology residency program. Can we collaborate?
Mm-hmm. Right.
Can two countries collaborate and say, look, our objective is 100 oncology with our 3 countries. You do this, you do this, you do this. What is so difficult about this? I mean, if we need to change, if it's really a challenging time, especially the past 1 year, and we really need to redefine what we are doing, I think we should start from here. And that is why the South-South collaboration, we're working together between countries, becomes really important. And that's why we thought about the consortium of medical schools. Can we look into this? Would this help change what's going on now? Because the path we have taken the past 6 years got us this far. And I don't think we went too far. I would start from the regional collaboration.
Did want to bring up research just for a second, just because, and I hope our welcome colleague is still here, just to say that I do think that research has also a role in increasing healthcare worker capacity, both like in the actual skill level, like we're, training nurses, I remember training nurses to like induce sputa and use a gene expert machine, like 10 years ago, and just the extent to which participation in research strengthens the academic and their questions and the way they think about problems and how they structure their programs to be able to evaluate them effectively, but also other healthcare workers who are working there. And I just wanted to mention that I think also as an economic driver. Getting back to our question, how does this create local economic opportunities? I feel like there are jobs that are created, when you have a surgeon, and then the jobs that support the surgeon, I think is an important part of the economic opportunities.
I was just
You
going
want to say something else? Yeah.
add that we have 2 HEAL alumni in rural India that are running an RCT on AI and community health workers and nurses, trying to see if you get better outcomes compared to some of the physician colleagues, because there's such a health workforce shortage. And I would say that them being from those communities and asking the research question and designing the research study is just much different than if it was designed elsewhere.
Super. Curricular competencies. We have a lot of questions in the room. So quickly, what are the curricular competencies that matter now?
I would go for the non-technical skills, the ability to think, critically think,
Yep.
to innovate, to look at a problem, convince yourself, I can fix this, innovate, and come up with a solution. The ability to lead and be led. And that conviction, I'm in this world for a purpose. To do this as much as I can and then move on. The soft skills, I think, in my opinion, are the technical skills can be learned. Anyone can learn technical skills, but the non-technical skills are, I think, the most important.
Sure.
I think we've seen with HEAL alumni a lot of the climate change conversation, just because it's impacting their patients so much. There's migrations or crop failure based on the level of heat in rural Mexico or rural India. So you have a lot of the fellows driving curriculum around how do I connect the dots between what my patients are experiencing and the climate realities. And so I think that's been interesting to see. We have one partner in rural India that because there's been so much crop failure, you've seen people flee to capital cities and get much more high rates of TB. They've started to address kind of organic farming initiatives as a way to address TB in that context. So I think, again, like being proximal to the problem that you're trying to solve, and then building in kind of these competencies that are very much informed from what people are seeing with climate change.
Anything you want to add to that?
I was just going to pivot back to research and thinking about the kind of importance not only for capacity building, but even with oncology therapeutics, we need appropriate representation of the patients who are actually going to get the treatments too. And one of the things that I've been trying to also be really mindful of is, if you are going to be doing something industry sponsored, then what is the downstream access for the patients, right? So if you show something works, then I think really ensuring that there's a conversation, with the kind of health sector to ensure that there's going to be some access framework that is thought of ahead of time in order to ensure that patients, if they are deriving benefit from a therapy, will get access to those therapies as well. So it's, I think, really important, not only just from the biological potential differences of some of these therapies, but I think have to be really mindful of the downstream access of the therapies as well, specifically for interventional trials.
All right. We have a little bit of time left. So can we have a hand? And I think we'll take one last question. Okay, please.
Okay. Abebe, maybe if I will ask you, I think one of the issues we are grappling in the WHO Afro is the issue of migration of health workers. Okay. Therefore, I don't know how would you help us try to come with a model in Africa in which we could try to say, because we have frameworks in the WHO, of course, are device but the member states actually have a different ideology and actual opinion on this. We're in a free world now, the people are able to apply anywhere. Mm-hmm. And the government, on the other hand, is saying, no, we have allocated resources to train these people from our own money. As a result, how do you balance that?
I would start from looking at them as humans. Migration, as you said, is a human right. You can't stop people if they are determined to leave. But what if we look at it differently and help them understand they're here in this world for a reason? They're Africans for a reason. Train them well. Train them in that setting. Take time in the rural setting. What UGH is trying to do. Help them understand your role in this world is to serve this community. Make a change here. Preferential options to those who don't have access. I guess that change might help. But the second, the most important thing is, again, let's not forget they are humans. They have needs. They are young people who want to get married. Probably would like to drive a car. Good school for their kids. They want to grow academically, professionally. Try to provide that. In other words, push factors, I'm sure we know very, very well. It's not because our professionals are being pulled from outside. It's because they are being pushed that they are rather leaving. And there are several publications. It's not money. The commonest pull and push factor is not money. So, again, being pragmatic and if I could also take a few seconds to throw another question. Governments tried to solve this by a strategy called flooding. Some countries said, okay, 100 doctors are trained every year, 50 of them are leaving. Let me train 1,000. This started about 15 years ago. Now, what is the continent facing? Except in 2 countries, the country has excess general practitioners that are unemployed. Have you heard of a GP driving a cab or an Uber in Africa? And we still say the workforce ratio is way below the expectation. So there is something wrong. There is something wrong. Doctors are being produced in excess, quote unquote. The system cannot carry them, cannot pay their salary. There are no hospitals where they can work. And yet there is no access to healthcare. So something is really, really wrong. Yes. It's only in 2 countries that this doesn't exist.
All right, I think we're at the end of our time together, but please feel free to approach the panelists at lunch.